So today we are talking from the 2017 ASCO international meeting, very exciting one, with a lot of hematological topics. And yesterday we had one specifically addressing the issue of doublets versus triplets therapy for the treatment of relapse myeloma patients. In introduction, I would like to stress that in Europe and in the US, we do not have the same perspective. In the US, you do have access to most of the new drugs, such as elotuzumab, carfilzomib, ixazomib, while in Europe, it is still not the case. Therefore, when we talk about triplets, in Europe, we have a limited number of options, while in the US, it's much more easy to use these so-called triplets. So the question is, could we give only doublets to relapsing myeloma patients? And the idea that I tried to develop yesterday was that indeed there may be a subset of patients who would benefit from a doublet instead of a triplet. However, it is fair to say that most, if not all, of the clinical trials that have been developed recently, all the famous randomized clinical trials combining mostly Revlimid-based plus carfilzomib plus elotuzumab plus ixazomib plus an Asst inhibitor such as panobinostat, they are all showing outstanding results, and for all of them, the triplet is usually superior to the doublets, with a gain of roughly around 6 months for the triplets. But one should mention, so far, no overall survival benefit. So it's a PFS benefit, and slightly superior when you combine carfilzomib plus Revlimid-dex with 26 months of PFS. The others are more around 20 months of PFS for Revlimid, ixazomib, Revlimid, elotuzumab, and a little bit less for Revlimid plus panobinostat. Starting from here, we even have better results when we combine this Revlimid-based or Velcade-based treatment plus daratumumab. This is actually one of the best triplets that we do have nowadays, and you are probably familiar with two of the most exciting trials, Castor trial combining Velcade-dex plus or minus daratumumab, and Pollux Castor combining Revlimid-dex plus or minus daratumumab. So the expected, and actually this morning, this Sunday morning at the 2017 ASCO meeting, we had another update of these two outstanding trials. However, one could argue that relapsed myeloma patients may be similar to frail patients, some of them. Frail patients with some comorbidities, and not too long ago, that was in a different setting, newly diagnosed and ineligible transplant patients. The IMWG, the International Myeloma Working Group, defined a score, a frailty score, and they were able to split 3 categories: the fit patients, the frail, and the intermediate, and they clearly showed that the outcome was completely different in terms of OS, PFS, And that was mostly related to the toxicity of the treatment and the discontinuation rate, which was 2 times higher in the frail patients compared to the fit patients. And you could translate this frailty score in the relapse setting, and indeed you do have in your clinical daily practice frail patients relapsing, and you may think for this specific patient population, again with also some kind of comorbidities that they could have got from previous treatment, that instead of giving what would be, yes, maybe the optimal treatment, but in fact not the optimal one, not such as a triplet, but more a doublet, and maybe not reaching right away the best response, but that would allow you to keep your patient on treatment. And this is the key point when you treat myeloma patients, and especially relapsing myeloma patients. So therefore, that could be the subset of patients where you may consider a doublet instead of a triplet. International recommendations have been made. The Mayo Clinic has published recently their recommendations on how to treat relapsed myeloma patients, and they suggest that most of the patients should receive a triplet. However, they specify that if you have comorbidities, you may consider a doublet. Philippe Moreau from France, and mostly for Europe, just published also the ASCO guidelines, and in his algorithm, you do have the doublets and the triplets, even though it doesn't specifically mention when can you use doublet instead of triplet, but it is mentioned. And I would finally mention the IMWG recommendations in 2016 in this setting, where it's a slightly different approach. They suggest that for high-risk patients, especially bad cytogenetics, you should definitely use a triplet. However, for, let's say, standard risk, more indolent patients, you may consider a doublet. So, in conclusion, for sure, if you can, it's probably better to use a triplet, but for the frail patients, for patients with comorbidities, and maybe for the indolent myeloma, you may consider a doublet instead of a triplet.